Hello, my name is Captain Jeremy Holzberg, and I will be presenting Anesthesia Breathing Systems. An anesthesia breathing system is defined as an assembly of components that serves as pathway for the delivery of gases from the anesthesia machine to the patient. Essentially, it is what links the patient to the anesthesia machine and extends from the fresh gas inlet to the point at which gas escapes to the atmosphere or scavenging system. An anesthesia breathing system consists of a series of ports that allow connection of the system to the machine, the system to the patient, as well as a valve through which expired gas is vented. A bag or tubing functions as a reservoir for gas. A CO2 absorber, if total rebreathing is allowed, eliminates expired CO2, and corrugated tubing allows for a flexible connection of components from the anesthesia machine to the patient. Now we will address some of the essential requirements and desirable attributes of a breathing system. It is imperative that gas delivery from the machine to the patient be accurate and timely. We want the concentration of gas set on our vaporizer to be the concentration that is actually delivered to the patient, not altered by our breathing system. Effective control and elimination of CO2 is crucial to maintaining patient homeostasis and avoiding hypo and hypercarbia. Recall from physiology that physiologic dead space includes anatomic dead space, or that portion from the conducting airway to the alveoli, plus alveolar dead space, which is that portion of the alveoli that is ventilated but not perfused. Mechanical dead space contains gas that is rebreathed without a change in composition. In other words, it is stagnant gas that is not delivering oxygen or inhalational agent, or eliminating CO2 or inhalational agent. Increased mechanical dead space gives the anesthesia provider less control of the gas delivered to and eliminated from the patient. Additionally, low resistance is required from the breathing system, particularly in spontaneously ventilating patients, as increased resistance imposes strain on the patient. Some desirable attributes of a breathing system include economy of gas, which ultimately gives us better control of the cost of our anesthetic; conservation of heat provides for improved thermoregulation of the patient; and humidification prevents drying of the airways and mucous membranes. We want our breathing system to be lightweight and convenient to use, and efficient during controlled and spontaneous ventilation, as well as adaptable to a wide range of patient ages and sizes. Lastly, we want our breathing system to provide for a clean OR environment, not contribute to the pollution of it. Now that we've discussed the components and physical and functional requirements of an anesthesia breathing system, we will learn about the classification of anesthesia breathing systems and how to differentiate between them based upon the presence and arrangement of components within the system, the fresh gas flow requirements of the system, the presence or absence of rebreathing, the performance of the system in spontaneous versus controlled ventilation, as well as the advantages and disadvantages associated with each classification. Dorsch and Dorsch outline 11 different methods of classifying anesthesia breathing systems that have developed over the years. Traditionally, functional aspects, such as the extent of rebreathing, and physical characteristics, such as the presence of unidirectional valves or a reservoir bag, were consolidated and used to classify the various systems. There is conflict between the various methods of classification, and with so many variables to consider, classification is confusing and ambiguous. For the sake of simplicity, we will limit this discussion to the classes outlined in our syllabus: open, semi-open, and semi-closed. Open systems, such as insufflation, where anesthetic gases are blown across the patient's face, and open drop anesthesia, where volatile agent is dripped onto a gauze-covered mask, are not commonly used in modern practice. These systems lack many of the requirements of a true anesthesia breathing system, and can be thought more of as anesthesia techniques rather than anesthesia breathing systems. The open technique is useful for pediatric inductions when the patients are non-compliant with masking, and with bronchoscopy during brief periods of apnea. While these systems do deliver anesthetic gas to the patient, they do so very inefficiently and with little control of the delivery. The advantage of the open system is its simplicity. With no tubing, valves, or bags, there is little that can go wrong with the system. They cause less disturbance to the patient than other systems, which is particularly helpful for anesthetizing children. However, the disadvantages of this system far exceed the advantages. Its simplicity and lack of components prevent controlled ventilation, assessment of tidal volume, control of gas concentration, and anesthesia depth, as well as face the patient and members of the surgical team at risk by not conserving heat or humidity and polluting the OR environment. The semi-open systems are non-rebreathing systems, so they lack unidirectional valves and CO2 absorption. Fresh gas flow must be high in order to avoid rebreathing of expired gas. The Mapleson circuit is an example of a semi-open system. Their efficiency in spontaneous and controlled ventilation is highly dependent on the arrangement of system components. The relative position of the components within the Mapleson systems determine the performance of the system and its classification. The open system is comprised of breathing tubes, an APL valve, and a reservoir bag. The semi-open systems are divided into two types, those with an afferent limb and those with an efferent limb. The afferent limb delivers fresh gas from the machine to the patient. Systems with reservoir bags placed in this limb, such as the Mapleson A, B, C, and LAC system, are known as afferent reservoir systems. The efferent limb carries expired gas away from the patient and vents it into the atmosphere through the expiratory valve. Systems with reservoir bags placed in this limb, such as the Mapleson D, E, F, and Bain systems, are called efferent reservoir systems. The Mapleson A, B, and C systems have the reservoir in the afferent limb and do not have an efferent limb. In the LAC system, the afferent limb has a reservoir bag and a coaxial efferent limb within the afferent limb that allows expired gas to be vented out into the atmosphere. The relative position of the components determines the system class and efficiency. These afferent systems work efficiently during spontaneous ventilation if the expiratory valve is separated from the reservoir bag and fresh gas flow inlet by at least one tidal volume of the patient, and apparatus dead space is minimized. Efficiency is lost during controlled ventilation with these systems. If the fresh gas flow inlet is close to the expiratory valve, as it is in the Mapleson B and C, the system is inefficient during spontaneous and controlled ventilation. The efficiency is a function of carbon dioxide elimination and fresh gas flow utilization, which is compromised by this arrangement of components. The LAC system is similar to the Mapleson A during spontaneous and controlled ventilation. The difference is the expired gas is eliminated via an efferent coaxial tube vented near the machine end of the circuit. This facilitates scavenging of expired gas. During spontaneous ventilation, the system is filled with fresh gas before connecting to the patient. Upon inspiration, the fresh gas from the machine and the reservoir bag flows to the patient, collapsing the reservoir bag. On expiration, fresh gas continues to flow into the system, filling the reservoir bag. The expired gas, consisting partly of dead space gas, pushes the fresh gas from the corrugated tubing into the reservoir bag and collects inside the corrugated tubing. Once the reservoir bag is full and pressure builds, the expiratory valve opens and the alveolar gas containing CO2 is vented into the atmosphere. During expiratory pause, alveolar gas that collected in the corrugated tube is also pushed out through the valve, as long as fresh gas flow is high enough. The system is filled with fresh gas and dead space at the beginning of the next inspiration, when fresh gas flow equals alveolar ventilation. If fresh gas flow is higher than minute ventilation, all of the alveolar gas and dead space gas is vented out of the valve, as well as some fresh gas. Some amount of alveolar gas will remain in the system and lead to rebreathing with a fresh gas flow less than the alveolar ventilation. Maximum efficiency is attained when the fresh gas flow equals the alveolar ventilation and the dead space gas is allowed to be rebreathed and utilized for alveolar ventilation. Less fresh gas is used. This explains why the Mapleson A is the most efficient for spontaneous ventilation. During controlled ventilation, the expiratory valve must be partially closed to facilitate intermittent positive pressure ventilation. On inspiration, the patient is ventilated with fresh gas, and part of the fresh gas is vented through the valve once enough pressure has developed to open the valve. During expiration, the fresh gas from the machine flows into the reservoir bag, and all the expired dead space gas, and alveolar gas flows back into the tubing until the system is full again. During the next inspiration, the alveolar gas, followed by the fresh gas, is ventilated into the alveoli. When sufficient pressure builds, a portion of the expired gas and fresh gas escape through the valve. This leads to significant rebreathing and excessive waste of fresh gas. For this reason, these systems are inefficient for controlled ventilation. The fresh gas port was shifted near the patient in the Mapleson B and C systems in an attempt to reduce rebreathing alveolar gas and improve the utilization of fresh gas during controlled ventilation. This position allows for complete mixing of the two gases, but makes it efficient in neither spontaneous nor controlled ventilation. The Mapleson D, E, F, and Bain systems include a 6 mm tube as the afferent limb that supplies the fresh gas from the machine. The efferent limb is a wide-bore corrugated tube to which the reservoir bag is attached, and the expiratory valve is positioned near the bag. In Mapleson E system, the corrugated tube itself acts as the reservoir. In Bain's system, the afferent and efferent limbs are coaxially placed. In order to reduce fresh gas flow requirements, efferent systems are constructed with reservoirs in the efferent limb. With similar functioning, these systems are efficient and economical for controlled ventilation if there is a separation between fresh gas entry and the expiratory valve of a volume equaling at least one tidal volume of the patient. They are not economical during spontaneous breathing. The Mapleson systems are modifications of the Ayers T-piece, which consists of a metal tube with a sidearm. In this configuration, it functions as a non-rebreathing system. Fresh gas enters the system through the sidearm, and expired gas is vented into the atmosphere, and there is no rebreathing. The dead space is minimal, as it is only up to the point of fresh gas entry, and elimination of CO2 is achieved by breathing into the atmosphere. To prevent air dilution, fresh gas flow must be equal to peak inspiratory flow rate. The Bain system is similar to the Mapleson D, but includes a coaxial tube that delivers fresh gas flow. During spontaneous ventilation, the breathing system should be filled with fresh gas before connecting to the patient. When the patient takes an inspiration, the fresh gas from the machine, the reservoir bag, and the corrugated tube flow to the patient. During expiration, there is a continuous fresh gas flow into the system at the patient end. The expired gas gets continuously mixed with the fresh gas as it flows back into the corrugated tube and the reservoir bag. Once the system is full, the excess gas is vented to the atmosphere through the valve situated at the end of the corrugated tube near the reservoir bag. During the expiratory pause, the fresh gas continues to flow and fill the proximal portion of the corrugated tube while the mixed gas is vented through the valve. During the next inspiration, the patient breathes fresh gas as well as the mixed gas from the corrugated tube. Many factors influence the composition of the inspired mixture. They are fresh gas flow, respiratory rate, expiratory pause, tidal volume, and CO2 production in the body. Factors other than the fresh gas flow cannot be manipulated in spontaneously breathing patients. Fresh gas flow should be at least 1.5 to 2 times the patient's minute ventilation in order to minimize rebreathing to acceptable levels. During controlled ventilation, intermittent positive pressure ventilation is facilitated by partially closing the expiratory valve so that it opens only after sufficient pressure has developed in the system. When the system is filled with fresh gas, the patient gets ventilated with the fresh gas from the machine, the corrugated tube, and the reservoir bag. During expiration, the expired gas continuously gets mixed with the fresh gas that is flowing into the system at the patient end. During the expiratory pause, the fresh gas continues to enter the system and pushes the mixed gas towards the reservoir. When the next inspiration is initiated, the patient gets ventilated with the mixed gas in the corrugated tube. As the pressure in the system increases, the expiratory valve opens and the contents of the reservoir bag are discharged into the atmosphere. Gas composition within the corrugated tube is influenced by fresh gas flow, respiratory rate, tidal volume, and pattern of ventilation, just as it is during spontaneous ventilation. The only difference is that these parameters can be totally controlled by the anesthesia provider and do not depend on the patient. Using a low respiratory rate with a long expiratory pause and a high tidal volume, most of the fresh gas could be utilized for alveolar ventilation without wastage, making for a very efficient and economical system. Some of the advantages of the Mapleson system are its simplicity, which translates to low cost and durability. A buffering effect exists within the system that makes end-tidal CO2 less affected by alterations in minute ventilation. Rebreathing of gases conserves heat and moisture. Resistance to flow is low in these due to the large caliber tubing, which decreases work of breathing, but the APL must be adjusted properly. Their light weight makes it less likely for inadvertent removal of the mask or endotracheal tube due to drag. The Mapleson D with an aluminum APL can go into the MRI. Disadvantages of the Mapleson system. High fresh gas flow is required, and that leads to high cost, pollution, difficult assessment of spontaneous ventilation. Also, potential hazard if fresh gas flow is altered, empty tank, loose filler cap.